Hello, everyone. Good to have you all here. Happy Saturday. Dr. Amin here from Toronto. We're going live today with Dr. Noor to talk about menopause, the very important transition phase of women's life. So, uh, if you have any questions, you can always write in the comment box or in the question bubble. And if we have a chance, we will go through the questions and answer some of those questions. Hi. Hi, everyone. Hope you're hearing me well. If you can just wave or send hearts so I know that you can hear me. And I'm going to invite Dr. Noor here. Thank you. Okay. Hello.
Hi, how are you?
Hi. Good.
So
Nice
nice
to
to see
meet you.
you. You too. Thank you for having me.
Lovely. So, how are you? Hope everything's good with you in this
Everything's
beautiful
great.
day.
Everything's great. It's beautiful here. You're in Toronto. I'm not far from you. I'm in New Hampshire and it's beautiful, stunning.
Lovely. And what day better than today?
I
It's World
know.
Menopause Day,
Yep.
so it's the best time to talk about menopause.
Absolutely. Absolutely.
Lovely. So, if you don't mind to introduce yourself to everyone here, all the viewers, that would be great.
So my name is Dr. Noor Hamidi. I am a family physician and menopause certified practitioner. I live and work in New Hampshire. I work in Exeter, New Hampshire. I come from a background of primary care and I started a practice nearly 2 years ago now, really focusing very much on midlife health in men and women. And really that's kind of really developed into doing a lot of menopause care, which is obviously, as you know, a huge gap in care. And it's been really wonderful. I've had great response and I think, it's probably my calling.
That's great. Very similar to me.
Yeah.
I'm the exactly background family medicine, and then I become board certified functional doctor. And last 5 6 years, pretty focused on very holistic type approach, personalized women's health and men's health to both. Yes, very good. So let's talk about menopause.
I'm ready.
Let's start. Yes. So let's start just by definition of menopause, perimenopause, very general for everyone here who doesn't know still about the definition and what menopause is.
So I think the definition of menopause is very problematic, and it's part of the reason that there's such huge barriers to care. Because the current definition of menopause is the point in time at which you're a year without a period. And unfortunately, that leaves a lot of women out. Isn't a useful definition in that it ignores the entirety of when women are actually symptomatic with their menopausal symptoms well before their last period. And we have a tendency to kind of ignore those patients and those women because we're super focused on this idea that menopause isn't until the last period. So unfortunately, so that's the current definition of menopause. And because the definition of menopause is about periods, it makes perimenopause, the definition of perimenopause, difficult to come by. I personally change the definition when I talk to patients, and we talk more about eggs and ovarian function. And we talk about how when we run completely out of eggs is when we're in menopause and our ovaries are not producing any more estrogen and progesterone. And in perimenopause, we're sort of running out of eggs. We've gone to a critical threshold of how many eggs we have on reserve. And so as a result, we're making a little bit less estrogen and progesterone, and it varies very much through from cycle to cycle. And that's the way I define perimenopause. But I think, do you agree that we have a problem with the definition of menopause?
Yes. So then we're missing
Yeah.
so many women or dismissing their symptoms just because they're still not by book menopause.
Mhm.
Yeah,
100%. And I
yeah,
think a lot of women see doctors who are even willing to give them HRT, but they're hung up on this idea that they cannot give HRT until they've had their last period. And really, when you look at the data around the loss of bone density, around the loss, the really metabolic changes that are happening in menopause, they're happening long before that last period. And so it's a huge missed opportunity in preserving bone density, preserving muscle mass, and improving our metabolic parameters if we wait that long to initiate the hormones.
yeah. I totally agree. And especially that we're still dealing with so many misinformation and fear and myth around menopause, around hormone replacement therapy. That makes it even more challenging for women. They're confused what to do, where to start. So, what do you say to women how to look for the symptoms and when to see their doctor? Do they have to do special tests, or what is normally how you approach and recommend to women what to do?
So I think the first sign of perimenopause is I don't feel like myself.
Mm-hmm.
There's a lot of focus on that there's going to be a change in the period. And I think that the change in the period actually is secondary. I think I don't feel like myself. Often a change in sleep pattern, maybe feeling a little bit more anxious, some mood changes. I just don't feel like myself is, I think, the biggest symptom of perimenopause. And, so I always tell people, it's going to be around, mid to late 30s into early 40s, maybe later for some women if they don't feel those symptoms, but around that, there's a kind of probably a 10-year, 15-year window that would be normal to have perimenopausal symptoms. So if you're within that 15-year window and you start to have symptoms thinking, I don't feel right, I've got changes in my sleep, I feel maybe a little bit more anxious, my mood is different, then you're probably in perimenopause. And I posted recently a reel showing estradiol levels and how they can be just absolutely wild in perimenopause. And we can go from 755 to undetectable over this, the course of a couple of weeks. And it kind of illustrates how there is a limitation to the utility of using lab work to diagnose perimenopause, because it's really hard to, it's going to be very, very labile in terms of levels. So I always tell people, you make a diagnosis of perimenopause by listening. We listen to what the patient, let them tell their story, and they will tell you. And it'll be very clear if you be quiet and let them tell you their story that the patient is perimenopause, because they're in the right age group and their symptoms sound like perimenopausal symptoms.
Yeah. So
Would
it's
you agree
more
with
of
that?
a clinical diagnosis rather
Mhm.
than testing. I mean,
Yeah.
I like to do tests too, but
Mhm.
I just not go with those numbers, especially when we do the blood test and serum check on hormones. It's just a snapshot. It's just that time of the day, the hormone levels, and this is not going to show us much about or deeper than what's going on. So it's good to have that base, even in
Mhm.
your 20s. I think it's good to have some base rate of your hormones just to be aware and track the levels. That would be helpful. It's a good guide, but not to determine that if you want to start hormones, if you're in perimenopause or menopause.
I 100% agree. And I don't know if I'm sure that you encounter this, but that this belief that hormonal changes can happen only in perimenopause and menopause. And I'm sure you see younger people, both men and women, and I routinely pick up abnormal, hormonal levels, high DHEAs or low testosterone in much younger patients. And they often present with very vague symptoms. Like, I'll give you an example. I think there's this cohort, I think, of patients who are presenting with allergy symptoms, like your eosinophilic esophagitis, that sort of symptom, chronic sinusitis in a young patient. And then you check their hormones and actually their hormones are off. And if you make a little bit of an adjustment in a young patient, you can often see improvement. So I think we have a problem with hormone replacement therapy or hormone therapy or MHT or whatever you want to call it. People get really hung up about what we call these things. I don't think it really matters, really. We're just helping people. But I think, this belief that it's owned by perimenopause and menopause. And I don't think that's the case. I think we have a huge group of people that we are totally missing that are much younger. And, you know, that we underdiagnose PCOS, we underdiagnose endometriosis, we know that. But I think there's a whole other group that we're underdiagnosing that have very small, you know, abnormalities. Maybe they have quite severe PMS, maybe they have PMDD, and all of those things can be really, you know, adequately treated in the hands of somebody that knows how to manage their hormones correctly.
Yeah, I agree. I agree. It's sad that we see so many people on so many different medications, a bag of medications, and then can easily they get treated with hormones or lifestyle changes. I do work a lot on lifestyle, and then we see so many people suffering with the hormone disruptors,
Yeah.
and
Mhm.
this is a major problem we see in um, kids with puberty, going through puberty much younger, and
Mhm.
women having problems getting pregnant and having
Mhm.
babies, and then early menopause. So I think hormone disruptors is a major problem nowadays
Mhm.
in our
I don't
lives.
I don't know if you've had this experience as well, and of seeing women with a history of fertility issues.
Mm-hmm.
And you know, I'm seeing a lot of these women that have had, you know, multiple rounds of IVF, whether successfully or unsuccessfully, and then, you know, they've had managed to maybe conceive, maybe not, but now they're maybe in their late 40s, and they've come to see me with these symptoms, and I've treated them, and then they're reflecting on how they felt for the last much longer than the last 5 years. It's more like the last 20 years that they felt that they're actually, on reflection now, that they feel so much better, that their hormones must not have been normal for all of that time. But I think when you get into the fertility space, that they're so focused on you conceiving rather than so focused on optimizing your health. I think that there's like a dissonance.
Yes. Yeah, we have I think this is a big, big problem with especially
Mhm.
women who are going through fertility. And
Mhm.
I always, especially when they're younger, in their 20s or 30s, I talk to them a lot about cortisol management,
Mhm.
stress management, that within like waiting for 6 months before you're going through anything else. And that sometimes itself coming out of a
Mhm.
toxic relationship, a toxic workplace. So it's so important these little changes in life, and then so all of a sudden they become fertile.
Yeah, yeah. It's really your body is responding to its environment. And if the environment is not conducive, you know, to normal function of the body, your body won't function normally. You
Mhm.
know, you have to create an environment for your body to thrive. And I have I do stress management in my practice, and I have a meditation and mindfulness coach. And when I tell my patients that they have to see her, they kind of roll their eyes at me. They're like, I don't know, I do yoga. I don't need to see a stress. And, you know, and it takes a long time for me to convince them that, you know, this stressor has a direct bearing on your biology. It's going to alter your biology. And you know what and I don't know, do you use CGMs in your practice?
I do,
Okay.
yes.
So
Yeah.
this is something that I find is so funny because they wear the CGM, right? And then they go away and they come back and we're talking about this. And I'm like, what's this spike here? And they're like, oh, I had a fight with my husband, or I had an argument with something, or I was stressed at work. And
Mhm.
I'm like, do you see the
Yeah.
literal biological response that your body has to
Hmm.
stress? And I think sometimes they have to see it in black and white to
Yes.
really believe it.
Hmm.
Mhm. So interesting.
So going back to menopause, which is,
Yes.
I call it, it's a pro-inflammatory stage of woman life with the estrogen decline. And estrogen is an anti-inflammatory hormone, which is, I mean, we see rise in inflammatory markers, CRP, TNF alpha, interleukin 6, all of those go up. We see rise in oxidative stress, mitochondrial stress, so
Mhm.
all at the cellular levels as well. We have all these little changes.
Mhm.
So lifestyle, if we want to focus on lifestyle, how to, before getting into any other treatments, lower the inflammation, what do you normally recommend your patients?
So number one, exercise. We have a DEXA scanner in our office, so we do body composition, and I love to do body composition because women are like, oh no, I lift weights and I'm strong, and you put them in the bot, and it's like, no, you're not.
Mm-hmm.
Your muscle mass is low, and it's a real wake up call for a lot of women. So exercise. is our first pillar, increasing our muscle mass. That's the I would say one of the biggest pillars to improving your metabolic health. Number two is diet and nutrition, really trying to pare back to a whole food diet, trying to avoid processed foods
Mhm.
where possible, which a lot of people struggle with. It's very different than how most people eat. And it takes a lot of effort to kind of make a plan for how that's going to happen. Avoiding toxins, so things like alcohol, and people don't like it when I say that, but alcohol is a toxin and you should not be drinking alcohol. Really thinking about, refined sugars in the diet, white sugar, white flour, trying to, again, back to kind of that whole grain idea, whole food idea, smoking, and then medications. And there's so many people out there currently, like, that use marijuana recreationally, and it helps them to, and these things are toxins, and we need to try to take as many toxins out of our body as possible, really to decrease our inflammatory state. And then the last pillar is stress management. And stress, as you know, is such a huge driver of inflammation. And, like I said, with the blood sugar, you can see it in black and white. If you're wearing a CGM and you get stressed, your blood sugar rises. So really, really stress management and working on our sleep. So it would be exercise, nutrition, sleep, and stress management would be the four pillars to an
Mhm.
anti-inflammatory lifestyle.
Wow. Yeah, I agree with all of those beautiful things. And then, of course, hormone replacement therapy is the icing on the cake.
Correct. Yeah.
So now let's get on hormone replacement therapy or menopause hormone therapy. So, and all the myths around it,
Yeah.
about the first on top of the list, breast cancer.
Mhm.
So when you hear another physician or practitioner send the patient back not providing the hormone replacement therapy, saying it could cause breast cancer because you had a breast cancer in the family, you're at risk, I can't prescribe you. What do you normally tell to these patients?
So it's, I think that question around breast cancer, it takes a level of understanding with, you have to break down the science. It's something that I think is, maybe you would agree, it's really patient to patient, provider to provider. It often requires, like somebody to really invest the time to have the conversation, willing to have the conversation with me, for me to help them understand that hormone therapy or estrogen does not cause breast cancer. So the first thing that we talk about is where that idea came from, and the WHI. And I always like to talk about, we can do it right now, but what happened in the WHI, how that information was misrepresented, and that hormone therapy does not cause breast cancer. We also talk about the fact that, women, when they're pregnant, have far higher estradiol levels than they will ever have in their lifetime, and definitely postmenopausally, even on hormone therapy. We're talking about, estradiol levels that are, 100 times less than you would ever have when you're pregnant. And so once they start to kind of unpack that, and you present the science to them, and those facts, I always say to people, if, estrogen caused breast cancer, then all pregnant women would have breast cancer, and they do not. So this is a myth, and it's not true. That said, I always tell people it's important, if you have a high risk profile of breast cancer, that we make sure that we do everything in our power to get you all the screening that's appropriate for you. So if you are somebody, I like to do the breast cancer risk assessment score, and if they qualify for any higher level of screening, we offer that screening to them. And then the third thing, whenever we're talking about breast cancer, women will come in and talk to me about, they're worried about their mother had breast cancer, and they're, want to talk about HRT, but they're scared of it, and yet they're drinking half a bottle of wine a night. And sometimes it takes a little bit of a reflection, like holding up a mirror. Like, if we want to talk about reducing our risk of cancer, we need to talk about what we actually know to be carcinogens,
Mhm.
right? So
Mhm.
things like obesity, things like abnormal blood sugars, things like alcohol, things like smoking, that are very obviously carcinogens, that if we really were committed to an anti-cancer environment for our body, we need to be making those choices for ourselves first. And HRT is not going to increase or decrease your risk of cancer. It's cancer neutral, essentially.
Exactly. Or in fact, it showed after many years observational studies confirmed that people who are taking estrogen have lower risk of having breast cancer. This is confirmed. We have it on studies.
Mhm.
And many years prior to Women's Health Initiative, women were on hormones and have very good quality of life. So it's nothing that we say last 10 years or 11 years, 20 years we have it. It's been there for at least 80 years with estrogen. So it was conjugated estrogen. So
Yeah.
at the time, synthetic. Still nowadays, there are countries, there are places, women on synthetic estrogen.
Mhm.
Although I do not prescribe, I'm sure you're not prescribing it too, but we know that it protects against many things, including breast cancer.
And colon cancer. We know that from the WHI data. It's
Mhm.
very clear that colon cancer risk was reduced. And I'm sure as more and more, we do see observational studies that keep coming. And I think as more and more women take HRT or, are able to access HRT, we're going to have more observational data. I don't think we're ever going to have, a double blind controlled,
Randomized.
trial like we had with the WHI. I just don't think that that's going to happen. But I do think that there is some utility in looking at, observational studies and gleaning this information. There's one of my favorite studies to look at is the UK Biobank study. The UK Biobank. So in the UK, I think it's 500,000 patients in the UK Biobank. So it's basically a bank of information, health information about those patients. So they've got labs and blood pressure and medication that they've taken, and all sorts of parameters. And the year before, they published data essentially looking at out of the 409 most commonly prescribed medications across the board, the 9 that were associated with the most longevity, and then the 9 that were associated with the lesser lifespan. And out of the 9 medications in the top, 4 of them were estradiol products. I
Yeah,
mean, it's you can't argue with it. It's like
yeah,
in black and white, you know?
exactly. I mean,
Yeah.
it's a queen of hormones. I love it, and
Yeah.
I really think it lowers risk of diabetes. It's just lowers LDL, rise in HDL, all of those. So it's neuroprotective, which is amazing. I mean, we have so many women suffering brain fog,
Mhm.
memory problems, mood disorders. So it's just. Uh, but again, the timing is important, when to start and what type of hormones. These are all important too. And as you said, it's very personalized, and we have to go each case and each patient on its own and decide what is best for them. So hormone replacement therapy, we talked a little bit about the myths around it. What about when to start it and when to stop? Again, this is a talk about a debate.
So when to stop? I posted a reel about this yesterday, this morning, but you do not need to stop HRT. There is no evidence that you need to stop HRT after a certain number of years. That is inaccurate. You only stop HRT if you develop a contraindication to HRT. That's the only reason that you would need to stop HRT. So stopping HRT, there's no reason to stop it unless you develop a contraindication. Like, for example, you develop a breast cancer that's estrogen positive, for example.
Mhm.
In terms of starting HRT, in my opinion, the earlier the better. If you
Mhm.
want to gain the preventative benefit from being on HRT for your bones, for your muscle mass, for your metabolic parameters, for your cardiovascular risk, the earlier the better. And that's going to be really long before your last period. So as soon as you start to have symptoms, so back to what we were talking about, this idea that I don't feel like myself. As soon
Mhm.
as you start to have, the I don't feel like myself symptoms, I start to think about it's time to be replacing your hormones.
Yeah, yeah. It's just about, well, what about the contraception? So, because we see this time there is a chance of having pregnancies as
Mhm.
well. So, what do you say to those women?
So, if we need contraception and the patient is having symptoms of perimenopause, I talk to them about a couple of options. My favorite option is a vasectomy. But if that's not an option, my second favorite option, my second favorite option is something like a Mirena IUD. very effective. It's set it and forget it. And also it's going to help lighten those periods. I'm sure you've seen, women present often with heavier periods during perimenopause because of those labile estradiol levels. So using a Mirena IUD or a Kylena or what, so basically an IUD that has a little bit of an impregnated progestin in it is going to be releasing a little bit of progestin into the local environment of the uterus. So it's going to have a number of effects. Number one, it's going to deliver contraception. So it's going to significantly lower your risk of getting pregnant, prevent a pregnancy. The second one is it's going to release that progestin into the environment of the uterus, keeping that uterine lining thin and lowering your risk of having heavy periods during perimenopause. And then the third benefit is if you treat that patient with estradiol, you don't need to worry too much about thickening the lining of the uterus. I still often will use a progesterone orally for that patient because often they have difficulty sleeping and they're anxious and, all of those things. But I'm not relying exclusively on that progesterone to keep that uterine lining thin. So that's my absolute favorite form of contraception because it allows us to treat the patient's symptoms adequately with bioidentical hormones whilst reducing a risk of a pregnancy. And then if that's not an option, I talk to them about oral birth control. And that is an option. There are forms of oral birth control that combine, forms of estradiol with a progestin. And for some women that can help them get, in control of their symptoms. And then another option that I have, which is similar to that, is to use something like a transdermal estradiol, which is my favorite way of delivering estradiol, but then giving them something like a progestin orally. So a progestin is going to be an oral progesterone-like medication that's going to keep that lining of the uterus thin, reduce our risk of pregnancy, also giving us that lining thinning associated with giving you estradiol, but allows me to also give the bioidentical estradiol at the same time. So basically what you can take home from that, there's so many options when it comes to women that are perimenopausal that need contraception. There are lots of different ways we can bring different things together to deliver the best symptom management that she needs.
Yeah, I do. I agree with you. I do use Mirena or Mirena coil. And on top of that, as you mentioned, I like still to give them progesterone
Mhm.
or prometrium. Most of the time we start cyclical and they love it. So
Mhm.
most of the time they say, why not to have it the whole
I
month?
want to take it every time. I know. I feel so much. I know I have the same problem. I want to take it every day. And that's fine. That's another thing. I think people get, very, very stuck. Like, oh, it has to be this way. If I'm perimenopausal, I have to take it cyclically, or I don't have to. There's not really a lot of rules around this. If you want to take it every day, you can take it every day. But you have to, at the very least, if we're relying on the progesterone as a form of keeping that uterine lining thin, you need to, at the baseline, take it cyclically. But if you want to take it every day, more power to you. I have no problem with
Exactly.
that.
Yeah. Yeah, same. Someone was asking about um, what if estrogen is above the normal highest limit in perimenopause? Could this be damaging?
No. So again, back to what we said, when we're in perimenopause, what we often see is very labile estradiol levels. So they're high 1 minute and they're low the next and they're high. And those highs can be very high. You can get, high, up to 1,000 I've seen, so high hundreds, 700, 800, 1,000. And they are not, no, I don't have a problem with that. A lot of people would label that person as estrogen dominant, which is inaccurate because the next minute her estrogen level will be low. And I would still treat that woman with estrogen if she was presenting with symptoms of low estrogen. But it's not damaging. The only problem with that, like we just talked about, is if you have high estrogens and they're very labile, that can often result in heavy periods or dysmenorrhea or intramenstrual bleeding. And so we need to make a plan for how we're going to manage that going forward. But this idea that because you have a high estrogen in perimenopause, you don't treat with estradiol is inaccurate.
Hmm. I
Do you
agree.
agree with that?
Yeah,
Yeah.
I do. I agree very much. And then someone is asking about spotting after being on HRT for 2 months. We do see that a lot, and that is not concerning. I normally actually warn patients that they
Mhm.
may have this spotting after starting hormone replacement therapy, and it may last for a few months. So we have to adjust the dose and the body get used and adjust to the hormone therapy. I don't know what are your thoughts on that. Do you send them for any special investigations?
I 100% agree with you. If it's within the first 6 months of an initiation of hormones or a dose change, I generally don't worry. We wait it out. And sometimes I will change some doses, maybe increasing a progesterone or decreasing an estrogen if it's persisting. But if it's persisting past 6 months, or if I have a patient that's been on HRT for a while and been cruising and been totally fine, and suddenly they develop bleeding, that needs to be investigated.
Mm-hmm.
But I think it's scary for some women, especially if they've had not had a period for 5, 6 years and all of a sudden they have bleeding. It's scary. So I agree 100% with you. I always warn people.
Yeah. Some of the questions here I go through. So, should one be on estrogen after hysterectomy for adenomyosis or endometriosis?
So
Uh,
there's some nice data on that, and there really is very little risk of recurrence of the endometriosis with the addition of estradiol. So I treat women with a history of adenomyosis and endometriosis routinely with hormone therapy to include estradiol, and I've not had a problem.
Yeah, I mean, I had a few patients coming from their gynecologists
Mhm.
declined estrogen because
Mhm.
of the history of adenomyosis or
Mhm.
endometriosis, and I started them on without any problem. So they love it. There is no issues or problems. It's just we closely monitor them and we start lower dose. It works beautifully.
Mhm. Do you use
I
a lot of testosterone in your practice?
I do, yes. Yes, yes, yes.
Tell me
I
about how you do testosterone and who you give testosterone to.
um I so most of the time I start with progesterone and then estrogen all together, and we wait. In many cases, they're good, they're symptom free, they don't need testosterone because, as you know, testosterone may stay good levels for many
Mhm.
years after menopause, and women don't need it. But then, in some cases, they still have problems, especially with fatigue and tiredness, or libido and sex
Mhm.
drive, which is approved reason for prescribing testosterone. But so I go with their symptoms. If they still have symptoms, we add in testosterone, and it works even with the body aches and pains, joint
Mhm.
symptoms, muscle problems, sarcopenia. So it works beautifully. I start small dose for women, either compound or the gel,
Mhm.
male gel testosterone, and it works beautifully.
Yeah, I would agree. And I also the other one that I think is so useful, and I'm sure you'll agree, is with cognitive function. If they still struggle with brain fog and
Yes.
memory loss, it's mind-blowing the effect that testosterone has on these women.
Mhm.
It's really amazing.
Yeah, and it's just, and I, again, with the physiologic doses, small doses, I
Yeah.
have not ever seen any side effects with
Mhm.
testosterone, like acne or hair loss. Never. Hair shedding, I have not ever seen in
Mhm.
any of my patients.
Yeah, I would agree. I mean, I would, yeah. I have patients sometimes that come to me from other providers that and their testosterone level is 500, 600 on their treatment and they don't feel well. And because it's not supposed to be that high. That's super physiological.
Yes.
We're not trying to give them male levels of testosterone. We're trying to give them physiological levels of testosterone to help them feel better. Yeah.
Yeah, so that's why I do not like giving anyone pellets. So, I mean,
Mhm.
I don't.
I don't either. I don't use
Yeah.
pellets at all. Mm-mm.
Yeah, so I always go with transdermal. Someone is asking about what dose of estradiol patch do you usually start on perimenopause?
So again, very variable. It depends on how symptomatic the patient is. And I'll usually start on the lowish end, but I very, very rarely leave people on the low end. I usually push that dose pretty soon, but maybe start on the 0.0375 or something like that for a patch dose to begin with, and then kind of check in with them routinely and see how they go. But again, it's very individual. If I have somebody that's really, really struggling, having terrible, terrible night sweats and hot flashes, I might start with a higher dose and see how they do.
Mhm.
But that comes from the history. You agree? Listening to the patient, what is the story, and then kind of making a decision. But you have to choose. You have to, at the end of the day, choose a dose And I always tell people the dose that I choose is not necessarily your dose, but I have to choose a dose to start with. And then we kind of
Exactly.
figure it out going forward.
Yeah. Yes. And I do definitely like to check bone density
Mhm.
levels there and see where they are. Maybe we then have to go higher doses for bone
Mhm.
protection or
Mhm.
reversing the osteoporosis,
Yeah.
osteopenia.
Yeah.
I like to check that. Sleep problems. So the sleep is a major problem that I myself experienced it as soon as I hit perimenopause. So, what do you normally do with the patients when they
So
have?
sleep is such an early presentation. And, I think a lot of women gaslight themselves because a lot of time they have, maybe they're postpartum and maybe they've got little kids that are waking them up at night as well. So I think a lot of they kind of blame those factors when
Mhm,
actually they're waking up because of their perimenopausal symptoms. And like we just talked about, sleep disturbance. And if you're not sleeping, that's going to drive your cortisol level. That's going to drive your blood sugar levels. That's going to drive your inflammatory markers. Sleep is absolutely central to being able to be metabolically healthy. So if a patient is having difficulty sleeping, which most of them do when they present, we very much focus on improving their sleep. And that's with a combination of things. I have my meditation and mindfulness practitioner in my office, and that's always a part of it, learning to, calm yourself, meditate using progesterone and estrogen. Progesterone helps people fall asleep. So it has that sedative effect in sleep induction, whereas estrogen keeps you asleep. So when people tell me I wake up at 2 or 3 in the morning, generally that's estradiol and not progesterone. If a patient tells me I cannot fall asleep, that's more likely progesterone. So generally a combination is needed to achieve good sleep. And I do use melatonin a lot. I like melatonin. It is something that decreases over time as we age. And so using a good quality melatonin and magnesium can be really helpful as well.
mhm. Yeah, talking about supplements.
Mhm.
What other supplements you use in your practice?
So I'm not, I don't have like a huge menu of supplements. I really like to focus on people's diet, and I have a dietitian in my practice, and we really, really try to hone in on people's diet. And if there's some things that they're lacking, we really try to replace it because, as you know, you're going to likely absorb it from your food much better than you're ever going to absorb it from a supplement. But I use a lot of magnesium. I use a lot of melatonin, vitamin D. We use calcium. We use omegas very commonly. And if, I have somebody it's winter and they keep getting sick, I might add in some C and zinc. It kind of varies. I do use a lot of fiber. Patients are chronically eating low fiber, as I'm sure you know. So we
Yeah.
do use a lot of fiber supplementation. We do use creatine as well. I would say those are the ones most commonly. I will also say a plug here that women are so commonly present with low ferritin and low iron, and they don't know it. And technically it's normal on their labs, but it's low. So I do a lot of replacement of iron as well.
Which helps with so many different things in especially this age.
And their sleep
Yeah.
often, and that's
Mhm.
another one we should have talked about with sleep. A lot of women will present with the restless legs, and it might be actually due to a very low ferritin.
Exactly. Do you see a lot of women during this period of time with gut health problems?
Yes. So many women present with bloating, changes in their stools. They, feel uncomfortable. They have a lot more, they feel really gassy. And that's because we know that our microbiome changes as we transition through menopause. There's data, that we can refer to that's very clear. We kind of transition to a different kind of group of microbes in our gut that are different than we had when we were premenopausal. So we talk a lot about gut health. Back to my dietitian, we have a whole protocol on how we really try to improve your gut health with your diet.
Mhm. Yes. So we have a shift in gut
Mhm.
microbiome, and not only gut, but vagina
Mhm.
microbiome. So
And
moving,
our mouth as
yes.
well. Yeah.
Yes, so we have dry mouth,
Mhm.
dry ears, dry skin, hair, everything
Mhm.
is dry.
Yes.
Lack of collagen and all the lovely stuff.
Yeah. Do you use any like face products, estriol, estradiol? Do you use that?
Yes, I
Yeah.
love it. I use it myself. And in fact, yesterday I was talking to a dermatologist
Mhm.
talking about low dose estrogen or estriol for skin. I mean, there's not really many studies about it, but it helps. It works. What works for down or up works.
I mean, it's the
But
same biological process. You know,
yes,
if your, vaginal tissue is thin and dry and angry and, bleeding, that's going to be the same for the rest of your skin
exactly.
tissue. It's
So
the
why
same.
not? I
Exactly.
love it. In fact, I make this compound in pharmacy. I ask them to make this concoction for me,
Yeah.
and my patients love it too. So I add, so it's not just estriol, but
Mhm.
some other things,
Mhm.
antioxidants and
Mhm.
anti-aging products, and it's beautiful.
So
And
nice.
I've been using it for last few years, and
Mhm.
it's good.
Yeah, I would agree.
So
I love
it's hard
compounding.
to say, is it really estriol on its own because we don't have that much data on it,
Mhm.
or is it adding vitamin C, hyaluronic acid, retinols, all of those good stuff?
I'm sure it's a combination of things, and I'm sure it's also, being on systemic estradiol is
Yes.
helping our skin and our vaginal health and everything. So I'm sure there's, it's a combination of factors, but I definitely love using topical estriol on the face.
Yeah, I mean, I see my patients who are on systemic estrogen. After a while, they say definitely the hair texture is better, their skin is glowing and is better. So it really helps even
Mhm.
after menopause
Agreed.
with
Yeah.
exogenous
Yeah.
hormones. It
Hmm.
definitely helps. So what about vaginal dryness and a low sex drive? So these are actually two different
Hmm.
topics.
Hmm.
Let's start with vaginal dryness.
So vaginal dryness is so common. It's like Dr. Amy Killen says, all female vaginas need estrogen. And I would 100% agree with that. All
Mhm.
female vaginas need estrogen. So vaginal dryness is very common. I think a lot of women say to me, "Oh, well, I'm not having intercourse. I don't need it." It's not just about intercourse. It's also about your, the integrity of the tissue. It's also about your risk of UTIs, urinary symptoms, fecal incontinence symptoms. There's a lot more to this. Is not just about having intercourse. I would say intercourse is down the list. When,
Mhm.
I'm sure in family medicine, you've worked in family medicine, and you know that women die of urosepsis
Mhm.
on routinely, which is basically sepsis due to a urinary tract infection. And that can be prevented with such a small intervention of using a little bit of topical estradiol to the genitourinary, the vagina, and around the urethra and the vulva and the vestibule. It's just such a simple thing. And the fact that it's not offered as a baseline to all women is really kind of, I think, unforgivable. So I would say all vaginas need estrogen. There are lots of different products. There's cream, there's pills, there's rings. I like to start with cream just so that we can get it all over, not just
Mhm.
intravaginally, but also on the vulva, on the urethra, on the perineum, because all of those tissues often need a little bit of estradiol just to kind of get themselves back to feeling normal. And then I'll switch them to something else if they absolutely hate the cream. And then we have a couple of different other products. I love Intrarosa. Do you have Intrarosa? Do you
Yeah.
use that routinely?
Yeah.
Vaginal DHEA. It's a really, really nice product that
Mhm.
a lot of my patients love. Our rate limiting step right now is that it's very expensive and often I
It's
can't get it
it's
covered.
no, exactly.
Yeah.
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 And then next is the sex drive and
Mhm.
libido, which is a very complex
Yes.
presentation. So multifactorial, I call it.
Yeah. It's
What do you do with women who complain about low sex drive or libido?
So the first thing I try to do with low libido is initially put the libido to one side and help her feel better. And often the libido will come with everything I'm going to do to help her feel better. So I'm going to give her hormones, both systemic and local. So, if the barrier to your desire is to do with sex and pain with intercourse, then we can fix that very easily. If you can't feel in the vulva, we can also fix that problem. If I make you feel better and you can sleep and you feel less wound up and stressed and anxious, then you're more likely to have desire. So I focus very much on her and making her feel better and getting her back optimized. And I find with all of those interventions, sometimes libido will come. A lot of times it will. If libido is still an issue, I might talk about adding testosterone, like you mentioned earlier. So
Yeah.
adding some testosterone can be really helpful for libido. I will say that it's a slow burn, though. It takes a while. I have people that I start on testosterone, they come back 3 weeks and they're like, my libido is still low. It takes time. Libido is a very, very slow, it's a slow burn. It's going to take a couple of months to feel that effect. So that's from a kind of hormonal perspective and making her feel better perspective. And then there are non-hormonal products that are available for libido that we do use. So Addyi is one, and then Vyleesi is the other one. So there's two non-hormonal products that I sometimes will use with some success for patients for libido.
Oh, good. I haven't seen, I have not ever prescribed any of those two,
Mhm.
but it's interesting. So you had good feedbacks about them.
Have Addyi, it's a medication that you have to take regularly for over a couple of months to see the benefit. I do have a couple of my patients that are on it and have very good results. Vyleesi works a little bit differently. It's more, it's an as needed thing. So if you kind of like Viagra, I suppose. So you use it on an as needed. It is injected, which is a rate limiting step. People don't love to inject things, and it seems to improve blood flow more to the kind of vulva and clitoris. So I think it's better for orgasmic dysfunction, that sort of thing, rather than kind of the psychosocial aspect of low libido.
I just heard like some side effects with them, like headaches or dizziness. So, but again, it all depends.
Yeah, very individual. Addyi can
Yeah.
cause dizziness, and that's why it's dosed at night. And generally, if it's dosed at night, it's not a problem. Vyleesi can cause headaches, and I have had that reported. Yeah.
Hmm. Yeah. Someone is asking again about fibroadenoma and if it's safe to have hormone replacement therapy.
Yes, it's safe
It
to have
is.
hormone replacement therapy. Yeah.
Um, I mean, in many, many cases, just to rest assured that its risks are really, really limited. And most women have benefits rather than risks. So benefits overweigh the risk or
100%.
outweigh risk.
Yeah.
So I just got estrogen cream for vagina. You're saying it can be simply applied rather than using the syringe to insert. Yes.
Yes, so
Yes.
people don't like the syringe. I hate the syringe. I tell people to dump the syringe and use your finger.
Um,
So I tell people to draw a line from the tip of your index finger to your second knuckle with your vaginal cream. Go inside the vaginal opening I'm going to do a demo. So if you were standing, you would do it with your finger facing forward and then take out your finger, and what's left on there, I would apply all over the
yeah,
clitoris, the vestibule, the
absolutely.
vulva, all over there.
Exactly. Yeah, it's definitely. What about, so again, I think, questions about if women have no uterus, do they need to go on progesterone? I receive that question a lot.
So do
Or
I.
is it just for estrogen and no need to get the progesterone?
So I get that question a lot as well. So I always explain it as progesterone has two utilities in the setting of HRT. The first one is it's really helpful for sleep. It's really helpful for anxiety, for irritability. It's important to know that when we were premenopausal, we made a lot of progesterone, especially in the second half of our cycle. So we're losing that progesterone and not making it when we are peri and postmenopausal. So we can present with symptoms as a result of that. So one reason that we use progesterone is for symptom management, for sleep, irritability. It has a calming effect on our body. And then the second reason we use progesterone is for this effect on the uterine lining. So when a woman has a uterus and I give her estrogen, that's going to thicken her uterine lining. So I need to give her progesterone because it kind of has the opposite effect on the uterine lining. So there are two utilities. However, just because a woman doesn't need it for this one, which is the uterus, doesn't mean that she doesn't need it for this one. So it's important that we set those two things aside. If a woman is having difficulty sleeping and is very irritable and anxious and angry, then progesterone might be a great option for her, whether or not she has a uterus.
Yeah, I do agree, and I do prescribe progesterone,
Mhm.
regardless of uterus or no uterus.
Mhm. And
Yeah.
even with people that have had, for example, I'm sure you agree, like who have a marina, or an IUD that don't, again, back to they don't need it for the uterus. I still will often treatment with micronized progesterone because they feel better.
Mhm. Yeah, definitely. One last question is about um, mood disorders.
Yes.
So a woman who comes to you in her 30s, how do you approach someone who comes with anxiety and depression and no other symptoms, mid 30s? What do you do for this woman now, knowing about perimenopause? Maybe 20 years ago, we didn't have this knowledge.
So perimenopause can present with psychiatric symptoms. So depression, anxiety, paranoia, associated with difficulty sleeping. Women can present with psychiatric symptoms due to their hormonal shifts. If I see a woman who maybe hasn't really had any mental health problems in the past and suddenly is presenting in her mid 30s or her late 30s with mental health problems, the first place I'm going to wonder about is her hormones. Because in terms of the timing, it's probably linked to her hormones. So I'll often do a deep dive in terms of where we think we are from her perimenopause perspective. And if we think it's perimenopause related, I'll treat her. And if she feels better, well, there's our answer. That's not to say that some women don't also need an anti-anxiety or antidepressant medication, or if they have ADD, to treat it. So it's important that we keep our eyes open, that we think of perimenopause early in our differential diagnosis, but it's also important that we don't just dump everything into menopause. And we also make sure that we are thinking about other potential causes of her symptoms.
I agree. Not missing iron deficiency anemia or
Exactly.
thyroid disease.
Yes. Yeah, but I mean, how many women? I'm sure you practice a very similar way to me. Do you see that make it into, she's 39, 40, and she's arrived and she's on, lorazepam and an SSRI that was started 2 years ago because she was struggling, and I spent a lot of time deprescribing these things.
Exactly. Yes. Yes. So do you think we address everything or most of the things about menopause? Anything else that I'm missing?
I think we
Or
addressed
you
most
like to
things.
talk?
I would say, parting comments, I would say to not really not gaslight yourself. These things, your symptoms are real, your joint pain is real, your difficulty sleeping is real, your whatever your symptoms are, it's real. And there's things that we can do to help. So I would say, advocate for yourself, speak up and ask for help.
Amazing. Definitely. I agree. It was great.
Thank you for
Lovely
having
talk,
me.
Dr. Noor. It was lovely having you here. Hopefully, we meet in person one
Yes,
day. We're not
definitely.
far, so
Hope you have a wonderful
yes.
day.
It was lovely. Everyone, thank you for joining us today. Hopefully, this was a informative talk, and I will save it and we can share it with you later. Lovely.
Take
Take
care.
care.
Enjoy
Have
your
fun.
Saturday. Bye.
Bye-bye.